really pleased to be here because I think there's actually a lot of overlap between what I do, I'm a heart failure clinician, and what many of you do in the room looking after older folks, because in fact they are the same patients. As just a way of introduction, we know that heart failure is a very common disease in Canada. In fact, there's probably more than 1.5 million people with heart failure currently. It is the leading cause of morbidity and mortality amongst amongst adults, and it is the most common reason to be in hospital if you're more than 65 years of age. Because of that, the clinical and economic implications of heart failure continue to increase, and these numbers are only projected to increase over the next few years. Just as a snapshot across Canada, it's estimated that about 1% of patients or adults have heart failure, and there is some regional variation there, but certainly the prevalence is quite phenomenal. And the incidence of the disease, as I've mentioned, continues to increase. We suspect that in another 15-20 years, heart failure incidence and prevalence may in fact double. And this is significantly a problem in older adults. This is a disease of the elderly, in fact. This is data from the United States, but if you look at the Medicare data, patients who are older than 65 years of age, heart failure is the most common cause of admission to hospital. And so what I thought I would do today is focus a little bit on a somewhat practical aspect of heart failure management in the elderly. I thought we'd talk a little bit about how we diagnose heart failure and some of the challenges relevant to the elderly population, and then discuss some of the important contextual medical management relevant to older folks, including a little bit about diastolic dysfunction. We'll talk about the use of diuretics and other medications in older folks, and then I'd like to spend some time talking about the role of devices. This is a very common topic in the management of older heart failure patients. Defibrillators, ventricular assist devices, pacemakers. What's the role, if any, of those medications? I want to tell you a little bit about some of the initiatives we're doing at the Heart Institute in collaboration with the TOH, looking at models of transitional care for heart failure, looking at palliative care in heart failure as a very important strategy, and one I hope to continue to build with our colleagues at the TOH. So I've already alluded to the fact that heart failure is a disease of the elderly. I've told you that across Canada, the prevalence of heart failure is about 1%. But as you get older, you can see that if you're older than 80 years of age, the prevalence of heart failure is 13 to 15%. So why is that? Well, some of it is clearly that as we get older, we develop other comorbid diseases that predispose us to heart failure, like hypertension and diabetes. But a big part of it is that we are doing very, very well at treating acute myocardial infarction and at treating acute heart failure. And so the reality is patients are living longer after that MI, and they're living longer after their mild heart failure. And so what they're developing at the end stages of their life is end-stage cardiac disease. In addition to the prevalence increasing with age, we also know that the mortality increases with age as well. This is our own data from Canada, published in the CCS guidelines, and you can see that the in-hospital mortality for heart failure is quite tremendous, 9 to 12%, much greater than just a simple myocardial infarction. And that when you're diagnosed with heart failure after the age of 65, overall, your one-year prognosis is actually much worse than you might think when you read clinical trials, with a one-year mortality that could be in upwards of 30 to 35%. And again, the same important message comes that the older you get, the worse your prognosis is for survival when you have a diagnosis of heart failure. Not only is your mortality risk greater with heart failure, but obviously the risk of hospitalization increases with age. And that's very important to me who treats heart failure patients, because there's something about a heart failure hospitalization that really changes the natural history of the disease. You know, heart failure is a disease that can get better and worse and oscillate over time. But every time patients get into hospital, oftentimes they recover, but they never quite reach that same level of wellness that they achieved before the hospitalization. And if you look statistically, you know that if you have a patient with class 3 heart failure who's never been in hospital, they have a mortality of about 10%. You put that same patient in hospital, now their one-year mortality is 30%. It's not that the hospitalization does anything bad for the patient, but it is an important marker of someone who's going to do
poorly in the next 1 year. And so there should be something very important about a patient who comes into hospital for heart failure. Some red flags should go up, and perhaps that patient should be transitioned into a more aggressive or more intensive pathway. Or perhaps that's the ideal time when we should be talking about end-of-life issues and advanced care planning. Oftentimes these are very important opportunities that perhaps we miss out on. So we'll step a little bit outside and talk about just screening and diagnosing heart failure in the older patient. And I don't have to tell anybody in this audience, many older folks come in with shortness of breath. And there are so many reasons why elderly patients can be short of breath. And many of them are non-cardiac. There are many cardiac reasons why your elderly patient's short of breath. And it doesn't necessarily mean they have pulmonary edema. In fact, the majority of patients with chronic heart failure don't have pulmonary edema. But just that low cardiac output or exercise-induced ventricular dysfunction can create a sensation of dyspnea. And that's very common in heart failure patients, older and younger. Many times it can be an equivalent or angina, my apologies, an angina equivalent. Many times it can be related to pulmonary hypertension. I appreciate that, thank you. 4067. And so when we evaluate these patients, it's important that we try to come up with a cause of their dyspnea. You all know that the diagnosis of heart failure really rests on the identification of high filling pressures and oftentimes signs of poor perfusion. But I can tell you that by the time the patient presents to you with florid edema or congestion or marked distension in their ventricular jugular veins, oftentimes that's the tip of the iceberg, and it often is the last stages of things that have lagged behind as the heart starts to fail, and it can be very difficult to pick those patients up before they develop marked volume overload. And this is even more challenging in elderly patients because elderly patients are often more sedentary, and so manifestations of exertional-induced dyspnea are harder to elicit. They may not complain of classic chest pain or ischemia. They may come in with very gradual sensations of fatigue or cough, weight gain. Many of these things can be attributed to other diagnoses that may not be heart failure. And so it takes a high index of suspicion to come up with a diagnosis. If you look at some of the epidemiologic data, it would suggest that by far and away the majority of patients that present with heart failure are doing so with dyspnea on exertion or dyspnea on rest. And although that has a very high sensitivity for heart failure, you can imagine the specificity of that is extremely low. And so although it's important to elicit that in the diagnosis, we have to think about other things as well. We often think of acute heart failure as patients coming in with florid pulmonary edema, sitting up at the end of the bed, hypoxic, doing very unwell. And although that is true, a significant percentage of patients do present that way. It is far more common for elderly patients to present with just a gradual worsening of their symptoms. And that's their acute decompensated heart failure. I feel more tired. I feel more fatigued. My dyspnea is worse. Maybe my weight is up. I'm more bloated in my belly. I'm more confused. I'm more forgetful. These, again, can be attributed to a number of things, but it's also a very classic way that heart failure patients come in. And in fact, 2/3 of heart failure patients will come in that way, not the frank, florid pulmonary edema cardiogenic shock that we also see in our CCU. And oftentimes it's because when we look at the cause of heart failure, most older patients with heart failure have preserved ejection fraction. They have diastolic dysfunction. And if you know, and if you've been involved in this, and we'll talk about this a little later on, diastolic dysfunction is very hard to treat, especially in the elderly. It's one of my biggest challenges. And so that's often something we need to, I think, work very hard at. If we look at the causes of heart failure in the elderly, they really mirror what we see in younger adults. The most common cause of heart failure remains coronary artery disease. And if you have coronary artery disease and if you have hypertension, your risk of heart failure increases significantly, especially as you age. But in addition to that, we really need to think about important other comorbid diseases in these patients as well, such as valvular disease, atrial fibrillation, and probably most importantly, because it has such a strong direct impact on our ability to treat these patients, is the concomitant presence of renal disease. And this, I think, is a very important message that we as cardiologists probably don't appreciate. Heart failure is not a standalone disease. I'm a heart failure specialist and I treat patients with heart failure. But especially when we're dealing with elderly patients, it's not their only problem. In fact, more than 2/3 of them have at least 2 non-cardiac problems, and 25% of them will have up to 6 important non-cardiac causes. It's estimated that about 30% of patients with heart failure, elderly patients, will have renal disease, something that significantly alters their outcome. Over 30% of these patients are anemic, whether that's due to renal disease, blood loss from anticoagulation, malabsorption, other things remain to be seen. 38% of them will have chronic obstructive lung disease. And so the differentiation between COPD and heart failure is another challenge. 25 to 30% of them will have depression, social isolation, arthritis, sensory disorders, cognitive disorders. These things are very common in patients with heart failure. And so although I'm here today to talk about the management of heart failure, we need as cardiologists to remember that these patients have other diseases that will impact our ability to treat and to manage their heart failure. One of the most important prognoses in heart failure is ejection fraction, and that's fairly intuitive. The lower your ejection fraction, the higher your risk of death. We also talk a lot about functional class. Patients who come in with NYHA functional class 4 will have an 8-fold increase in mortality relative to the class 1 or class 2 patient. And so just these 2 markers of prognosis can really help us to understand how we need to manage and what we need to think about in terms of that patient with chronic heart failure. I've been asked often about the role of BNP, and certainly BNP is very good in prognosticating heart failure and also very good in helping us to understand the cause of dyspnea in somebody who presents with undifferentiated dyspnea. Unfortunately, we don't have access to BNP routinely at the TOH, but it certainly can help us in our diagnostic strategy, especially with older folks when we're really not sure why they're so short of breath. When we look at patients with acute heart failure, we see that there are also very important key elements that emerge. So when patients are admitted with decompensated heart failure, and this was a registry called ADHERE, which is a large national registry of admitted heart failure patients. Many of these are older patients. They looked at a number, over 32 variables to predict heart failure. And what they identified, and again, it's somewhat intuitive, that low systolic blood pressure, a high BUN, and a high creatinine, defined as a creatinine greater than 243, UN greater than 15. If you had all 3 of those things when you came into hospital, your in-hospital mortality was 26%. Very powerful data. It's easy to do at the bedside when they come in. And so again, I think that it helps us to understand how we manage the patients, but when we talk about patients who have end-stage disease, I think it also helps us to prognosticate and to plan in advance as to what this person's next 6 months or 1 year might look like. All of these elements that we've discussed are really there to help us with diagnosis and to help us with prognosis. And we've worked with the Champlain Cardiovascular Prevention Network to come up with a screening tool for family doctors for the diagnosis of heart failure. And I apologize, the font is very small, but the slides will be available online. But essentially it comes down to the idea of starting with a high clinical index of suspicion, screening those patients in whom you think they might have heart failure, the patients with diabetes or obesity or alcohol-related disease, and looking for those important signs and symptoms of heart failure. And that if you do suspect heart failure, we believe that all patients should have an echo, should have an ECG and a chest x-ray and blood work to look at some of those key prognostic variables. And that it's unlikely to be heart failure if the echo is completely normal, if the JVP is normal, and if they have no signs and symptoms of fluid retention. And on the other hand, it almost certainly is heart failure if they have a history of cardiac disease, if they present with things like orthopnea and PND, which are very sensitive for heart failure, if they have high neck veins, or if the ecocardiogram suggests systolic dysfunction or significant valvular disease or significant diastolic dysfunction. And with that clinical approach, you can really put these patients into one of 2 buckets. Unfortunately, many of them will fall into the 3rd bucket, which is, I'm not really sure if it's heart failure. Maybe they don't have any signs of fluid retention. Maybe the echo is a little bit abnormal, grade 1 diastolic dysfunction, but I'm not really convinced it's heart failure. And oftentimes I'm in that bucket as well. I don't know if it's heart failure. And what we recommend to family doctors is that they get followed symptomatically, and that you look for an alternative diagnosis. And if you don't have an alternative diagnosis, then consider empiric treatment for heart failure, diuresing them, see if they feel better, educate them about their symptoms, and most importantly, follow them. See them again, because if it is heart failure, it will progress. You will see that. And if it's not, then ideally some other diagnosis will surface. So I'd like to spend the bulk of my talk today talking about some of these complex management issues in the elderly patient with heart failure. We've already discussed that heart failure is really a continuum along the cardiovascular spectrum, and unfortunately it tends to be at the end of this continuum, and that this disease really starts with atherosclerosis for most people, which leads to myocardial infarction, myocardial remodeling, arrhythmia, and then unfortunately heart failure, and in many patients end-stage disease. And because this is such a known projection, the ACC, the American College of Cardiology, now says there are actually 4 stages of heart failure. And although I live in stage C and stage D heart failure, which are those people who have symptoms of the disease, we should actually identify heart failure at stage A. Patients who've never even had a cardiac problem, but they're at risk. The diabetic, the obese person, the person with sleep apnea and untreated hypertension, that we should be really thinking about heart failure, even in our elderly patient, and treating those risk factors. And then, of course, once they develop structural disease, or stage B heart failure, then there are other therapies we can tailor. And of course, this leads nicely into a discussion of functional class. And I've already talked to you about how important prognostically functional class is in terms of identifying the severity of the disease. But really, unfortunately, many patients do present to stage D disease, where they get referred to someone like myself, where we are discussing very advanced and high-risk surgeries or cardiac replacement strategies or end-of-life care. So you've probably seen a slide like this or this slide before, and it's a very simple algorithmic approach to the management of systolic dysfunction, of heart failure with low ejection fraction. And it was put out by the Canadian Guidelines for heart failure a few years ago. And it suggests that everybody with low ejection fraction should be treated with a beta blocker or an ACE inhibitor, and we should titrate that as much as we can. And if they're still symptomatic, we should add other medications like digoxin or nitrates or aldosterone antagonists, and we should be thinking about devices. And I'll come back at the end to maybe how applicable this is overall to our elderly patients. But what does it mean for our elderly patients? Well, we have to be cognizant of the fact that these drugs are not benign, and they're especially not benign in older folks. And there's a number of physiologic changes that happen with aging that can potentially potentiate the effect that patients get when they get treated with these medications. Their cardiac reserve is impaired or decreased, and so they may be exquisitely sensitive to negative inotropes like calcium channel blockers. And because of their vascular compliance and their changes in blood velocity and aortic compliance, their output may be markedly decreased if you start them on a beta blocker. Clearly, we know they have decreased baroreceptor sensitivity, and so we've all seen the orthostatic hypotension that is so profound when we start these patients on vasodilator therapy. And we know that because polypharmacy is a big problem for our older patients, side effects can even be further compounded. They can be very sensitive to medications which suppress the AV node. And so things like beta blockers, digoxin, or calcium channel blockers need to be considered with very gradual titration and very slow initiation. Oftentimes I get asked, if I have a patient with low ejection fraction, what medication do I start first? Beta blockers, ACE inhibitors, both at once? And in fact, there's good evidence to suggest it doesn't really matter which one you start, but ideally you want to get both on at some point. And I think that principle holds true in our older folks as well. But I would caution you, as you already know, that those medications often do not reach the doses or the target doses that you see in clinical trials. And that's okay, because we do know that although there's a dose response, some drug is better than no drug. I'm not going to belabor the point. I think we all are very confident with the understanding that beta blockers save lives in heart failure. They've been studied for many years, and compared to placebo, you're looking at 30 to 40% relative risk reduction in terms of mortality. And whether you look at asymptomatic patients, this was a study of asymptomatic patients on beta blockers who've never had heart failure but have LV dysfunction. This is class 2 patients and this is class 4 patients. Regardless of the severity of your heart failure, you benefit from a beta blocker. What about beta blockers in older patients? Well, if you actually look at the clinical trials, these pivotal clinical trials, many of them did in fact enroll patients who were up to 80 years of age, although I agree they represented a small proportion of patients in the study. There was one very nice meta-analysis that was published that took 5 of these pivotal trials and dichotomized patients to above or below the age of 65, and they showed that even above the age of 65, the mortality benefit was there and consistent. And there was actually one randomized trial that looked at a very selective and not well-used beta blocker in elderly patients, and they did show that there was a reduction in death. So I think the wealth of evidence that can apply to our elderly patient population is that these medications do work. But clearly they are at risk of conduction disease, fatigue, lung disease exacerbation, and so we have to watch it very closely. Well, how good are we treating elderly patients with beta blockers? The data would suggest, registry data would suggest that we're actually pretty good. In patients who are exclusively managed by family doctors, the uptake of beta blocker perhaps is a little bit less than that seen in specialty care, but overall, not marked differences overall. Well, it often comes up the question, well, maybe we're not using them as much because they're not tolerating them, and I have no arguments with that. There's been a couple of studies that have looked at tolerability in beta blockers and have shown that they're actually quite tolerable. The big caution with that, of course, is this is randomized data. So clearly any patient who didn't tolerate the drug wouldn't have been enrolled in the trial or dropped out. So that data has to be taken with a grain of salt. Well, one potential alternative to beta blocker may be a new drug on the market called ivabradine. And ivabradine has been recently studied in heart failure patients, and what it does is it inhibits the sinus node. So the advantage of that is it slows your heart rate down, but it has no effect on your inotropy. So it has no negative inotropic properties. It doesn't affect the AV node. It purely just decreases sinus rhythm. And compared to placebo, this drug had marked improvement in morbidity and mortality in heart failure. I caution that not a significant amount of patients were older in this trial, but it certainly is intriguing to think that there may be a way to slow heart rate down that doesn't have a lot of systemic effects, and perhaps this may help our elderly patients. Moving quickly on to ACE inhibitors. Without a doubt, this is the time of consensus when one-year mortality in heart failure was 50%, and ACE inhibitors save lives. And we know relative to placebo, whether you're post-MI or you have heart failure, you should be on an ACE inhibitor. And again, subgroup analysis suggests that whether you're older than 70 or not, you're going to benefit from an ACE inhibitor, and that all patients who have no contraindications to such should be started on an ACE inhibitor. But again, practically, in our older folks, I've already told you 30% have chronic kidney disease. And so if you're going to start that medication, that's great, but start it very low. And you have to be very cognizant of the potassium and the creatinine, and I watch these very closely in my older folks. Aldosterone antagonist is another drug that's used commonly in advanced heart failure. Early on in the days of rails, there was a marked reduction in morbidity and mortality. And then most recently, a couple years ago, the emphasis trial looked at patients with class 2 heart failure. And again, showed relative to placebo, this study was stopped early because of these huge reductions in cardiac endpoints. This is systolic dysfunction heart failure. So it is a great drug, and I'm a big fan of it, but this is what can happen. On the top, you see, this is Ontario data, Medicare data, so patients older than 65 years of age. And you see this is the prescription rate for spironolactone. When that study, the RAILS study, was published, this is what happened to the prescription rate for aldactone. It went up dramatically. On the bottom graph, you see the admissions to hospital for hyperkalemia in Ontario. And so, concurrent to higher use of the drug was a marked increase in admissions for hyperkalemia. And hyperkalemia is not a benign problem. And it is our problem because we're responsible to monitor it. And in fact, in the real world, only about 20 to 30% of patients have their serum potassium checked after this medication started. And so I don't use this medication if their creatinine is elevated significantly or if they have a history of hyperkalemia, and I'm very cautious about starting it in older folks. And I certainly make sure that I do blood work within a week of starting the medication. Talk a little bit about heart failure with preserved ejection fraction. For the event of time, I'm going to skip through this case. But this is, as I said, the most common cause of heart failure in the elderly, and it is also the most difficult to treat. Because there is no algorithm for treating this disease. It really is a constellation of hypertension, diabetes, renal disease, sleep apnea, and obesity. And if you really want to treat this disease, you have to treat all of those other things. And those other things can be very challenging to treat, especially for cardiologists. And so I don't have an algorithmic approach because there really is none. But the principles are that if you have an elderly patient with heart failure and preserved ejection fraction, the number one idea is to control their blood pressure. Drive that blood pressure down as low as you can, usually ideally less than 130 on 80. If they're in atrial fibrillation, control their ventricular rate. Or consider rhythm control if they still have symptomatic heart failure. Look at the role of salt and fluid in these patients, because for whatever reason, these patients are exquisitely sensitive to salt and fluid loading. And so teaching has to be a big part of this. If I was going to use medical therapy, there is some evidence perhaps. Certainly RAS therapy helps in hypertension, and it may help regress LVH, so that makes sense. There was one study that looked at beta blockers in elderly patients with diastolic heart failure, and although this was observational, it did suggest that there might have been a mortality benefit. Very weak evidence, but a signal that if they have another indication for a beta blocker, it's probably not harmful to start them on this. And then, of course, diuretic strategies are very important. Acutely, when patients are decompensated, I strongly recommend the use of intravenous diuretics, usually at a higher dose than what they were getting at home, with cautious, again, monitoring of potassium and renal function. And although diuretics are very important symptomatically, we all know that there's an association between diuretic use and death. And whether that is just a reflection of a sicker patient or due to a direct relationship or harmful effect of diuretics, we don't know. Studies like this one suggest that the higher diuretic dose you're on, the worse your outcome is. But again, whether that's cause or effect, I'm not sure. Practically, when we're starting elderly patients on diuretics, we have to make sure that they have the ability, the cognitive ability, to manage this or to have some help with management in terms of fluid restriction, salt restriction, weighing themselves. And challenging cases should be referred on for specialty care. Ideally, a titration schedule is helpful for the families, and then our responsibility, of course, is to monitor the electrolytes and the renal function quite closely. I'd like to spend the last few minutes talking about device therapy and some of the strategies we're working on. And again, for the event of time, I'm going to skip through the case. But when I talk about devices, I'm looking at two things. I'm looking at defibrillators and resynchronization pacemakers. Defibrillators do nothing for quality of life. They are purely there to save your life. They are there to extend your life by shocking you when you have some malignant ventricular arrhythmia. A cardiac resynchronization pacemaker is there to help improve both the quality and the quantity of your life. Just for you who are not that familiar with defibrillators, they are pacemakers. They sit in the right ventricle, often a lead in the right atrium, and they monitor your heart rhythm continuously. And there's a wealth of data to suggest that defibrillators save lives. Well, do elderly patients benefit from defibrillators? This was a prospective cohort that looked at about 1,400 patients over time. And you could see that as we went from less than 2,000 to currently greater than 2005, the proportion of patients who received an ICD at older ages increased. And after 2005, 14% of patients getting defibrillators were older than 75 years of age. And so the question is that appropriate? Well, we know with age, your mortality increases, and the cohort of patients who were the oldest had the highest death rate over 5 years. And on the top, you have the rate of what we call appropriate therapy, so either getting a shock or being paced out of a malignant rhythm. And on the bottom, you have the rate of appropriate shock. And if you stratify it by age, you can see there's no difference. And so the authors conclude that whether you're 75 or 55, the probability of benefit from a defibrillator is the same. That the incidence of shock, of appropriate shock over 5 years is the same. And so they hypothesized that yes, defibrillator therapy is appropriate because the risks and the benefits are actually ideal. Although, when you look at the cohort greater than 75 years of age, following a shock, they had a 1-year mortality of 35%, compared to 16% in a younger cohort. And so maybe it's appropriate to implant the device in certain individuals, but it's also just as appropriate to talk about when it's maybe not continue to be appropriate to have that therapy still active. It's been suggested that older people are at greater risk of the problems related to defibrillators, and in fact that hasn't been seen. They are just, the rates of infection and lead dislodgement are similar. So resynchronization therapy involves a third wire that goes into the coronary sinus and paces the left ventricle. And what that does is it helps to improve cardiac performance. Patients feel better. Unlike with a defibrillator, they actually feel better. And again, wealth of data suggests that these pacemakers can make you feel better and live longer, even if you have mild heart failure. This study came out of the RAF study published recently primarily from Ottawa. Well, do elderly patients benefit from this therapy? Again, this is sub-study analysis from some of these large pivotal trials, but on the left, on the right, you see patients who are between ages 60 and 74, and you see that absolutely there's just than if you just have the defibrillator alone. Once you get over 75 years of age, the curves don't separate as much. Now, there was improvement with resynchronization pacemaker. It was a 30 or 40% event reduction, but it wasn't statistically significant because the cohort of patients even getting these devices was very small. So we're really left with indecision about what to use in terms of device therapy for these patients. And we look to the guidelines to help us to make some of these decisions. But how applicable are these guidelines to the elderly cohort? And a very nice study published recently in the Canadian Family Physician Journal looked at 10 Canadian guidelines and asked that question. What are the key elements that we want to see as patients treating elderly patients regularly, and are they addressed in the guidelines? And in fact, the heart failure guidelines did fairly well. Although they didn't define what an elderly patient was, they did address important comorbidity, psychosocial issues. They did talk about the importance of balancing the time needed to treat benefit in the context of life expectancy. They did also address barriers to implementation, and they discussed the quality of evidence as it relates to older patients. And so I do think that there is good support we can get for the guidelines with respect to heart failure management. One of the things that we do frequently in the Heart Institute is we help to manage these patients at home with home monitoring, which is a strategy where we monitor their blood pressures and weights on a daily basis to assess for decompensation. And although 2 recent randomized trials have suggested that this strategy doesn't actually help in heart failure, there are a lot of limitations to this data. And in fact, if you look at a meta-analysis of many of these home monitoring strategies in heart failure, you can see that there's a trend benefit towards mortality and a significant benefit on heart failure admission. And so there's a lot of things that go into whether a management strategy is effective or not. But depending on what that strategy involves, I do think there is a benefit. And in fact, one of your colleagues here worked with Christine Struthers, our home monitoring nurse, and recently published this paper that looked at how we utilize home monitoring here in Ottawa. And this cohort looked at over 600 patients and looked at older and younger folks defined by age 75 and found that we actually have the same results when we use home monitoring in older folks. That they're not at increased risk of admission for heart failure, that they're not using more resources, and so it suggests that the management is actually quite appropriate, and it may in fact be a good way to help to look after our older patients. Well, we use home monitoring because of this. Our biggest goal is to decrease readmission in heart failure, and we know that the 30-day readmission rate for heart failure is 25%, and that's here at the TOH and across the board. And we know that a big problem with readmission is the lack of standardized care in the transition back to home. Here in our own LHIN, as I've said, our admission rate, depending on the hospital, at 30 days ranges from 25 to 50%. And if you do the math, it works out to over $1 million per year. And these are preventable, what's defined as a preventable readmission here in the Ottawa LHIN. So we clearly have work to do with respect to readmissions. There's many reasons why patients are getting back into hospital. Many times it's appropriate, but many times we probably could do better. We've been told that the discharge summary is not very good. We clearly have issues with respect to medication reconciliation, and the follow-up of patients is often not well defined, either for the caregiver or the patient themselves. And this, of course, is a very important influence. We, I think, as cardiologists especially, don't really appreciate the impact of cognitive impairment on outcomes. It's been estimated that up to 25% of our patients have significant cognitive impairment. And that's not something that as a cardiologist I think we think about. But clearly, if they have cognitive impairment, then if we identify that, then perhaps we can transition their care in a more appropriate and tailored way. Simplifying their medication regimens, getting more assistance at home, or tailoring their educational needs so that we can prevent that readmission. And this very nice study, which was just published about a month ago, looked at admission to hospital for heart failure. And what they identified was that in patients admitted, and they used the Folstein Mini Mental Status Exam, 47% of them had cognitive impairment. And a significant proportion was defined as moderate or severe. But this is where I think it gets interesting and reflects our own perhaps neglect of this, is that of those 47%, only 23% of them was cognitive impairment even identified on the discharge summary as a problem. And those with cognitive impairment were significantly, had a hazard ratio of 2 or 3 times greater of getting back in hospital. And this, I think, is very thought-provoking. When they looked at the influence of identifying cognitive impairment, they found that if you had cognitive impairment but it wasn't documented on your medical record, you were much greater, much more likely to get back into hospital. And again, and that wasn't seen to the same effect in patients in whom cognitive impairment was documented. So I think there's something very important about our ability to recognize cognitive impairment and tailor a strategy at the time of hospitalization to prevent them from getting back into hospital. I'm going to skip through some of the, we're working on a transitional care program here in heart failure that really involves a number of these elements, including starting with discharge planning when they get into hospital, not on the last day, assessing their needs, putting them in a complex program of home monitoring, and then really offering the family doctor a number of supportive strategies to help to look after that patient when they leave hospital. One of the things we're going to be rolling out at the Ottawa Hospital, or at the Heart Institute in the next couple of weeks, is a standardized discharge summary. And again, you can have these slides online, but you'll be seeing this in some of your patients who are discharged from heart failure from the Heart Institute. And what we've done is we've incorporated a lot of these elements that we know need to appear on the discharge summary but haven't in the past. And this comes out of work we've done with the family health teams in the Ottawa area, as well as some of your colleagues who have been very involved in a heart failure leadership table. So in the last couple of minutes, I want to talk about end-of-life issues, because I think this is very important in heart failure. And there's been a number of very interesting publications on what we should be doing and perhaps what we're not doing. Well, everybody agrees that in heart failure, preparedness planning is very important. And I can tell you that that, again, is not something cardiologists, as cardiologists, we do very well. But we really need to educate patients better about their disease course and their prognosis. Symptom management in heart failure at the end of life is often very difficult because we often overlook the symptoms that aren't frankly cardiac and perhaps don't treat them as well as we should. And from the palliative care side, we have to develop an understanding that some of the medical management in heart failure is palliative treatment, and it's very different than a withdrawal approach that you see in very end-stage disease. And that ideally there needs to be collaboration between disciplines. And at end of life, when patients get into life, in heart failure, it's very interesting because you often have parallel use of life-prolonging medications and palliative therapies at the same time. And an example of that is we often talk about home or intravenous milrinone, an inotrope, in palliative care. And so it seems counterintuitive, but from our perspective, it makes a lot of sense. And again, we can't do this well without collaboration from your folks and from palliative care. Well, what about this defibrillator? I've talked about the benefits of the defibrillator, but unfortunately we haven't spent enough time talking about why not get a defibrillator. And we don't have that discussion, at least the evidence suggests we don't, as much as we should. Patients frequently, when surveyed after a defibrillator, don't really understand why they have it or what the purpose is. And they don't really understand, especially older folks, what alternatives to defibrillators are. We also, the evidence suggests that we don't talk enough about when to turn it off. So these batteries, they die, and we change them. And that's a great time to have that discussion with the patient. But again, the evidence suggests that we're not having that discussion. We're also not having the discussion that when you have a defibrillator, there's a trade-off between your mode of death. Sudden death versus death from pump failure. Oftentimes, the latter death is a much more uncomfortable death. And so we need to be honest and forthcoming in our patients when we have this discussion. And we believe in heart failure that all our patients should have a process for elective defibrillator deactivation. They should know that it's very easy to turn it off if you want to turn it off. And that we should know how to do that and when they want us to do that for them. Resynchronization pacemakers do help patients feel better, and it improves their quality of life. But there are some scenarios where patients want everything turned off. It's important to discuss that turning off a resynchronization pacemaker could exacerbate or accelerate their symptoms. And not for the discussion today, but as we move more and more into advanced therapies for heart failure, we have left ventricular assist devices, which initially were used just as a bridge to transplant, now can be used as destination therapy. And so I am getting referrals of patients who are 65, 70, even I had a referral of an 80-year-old patient who wanted to be considered for this type of device to prolong their life. And there's a whole host of ethical and medical and great discussion we can have about that at another time. So we believe that palliative care is an important aspect in heart failure and one that we want to improve. And so we're also rolling out a program at the Heart Institute where, in support with Dr. Azad has been very involved in our palliative care team, where we are actually just going to start with a screening in heart failure. And again, I apologize for the small font, but when our patients are admitted to the Heart Institute with heart failure, the cardiologist is going to be asked that pivotal question: would you be surprised if this patient died in the next 6 months? And if you're not surprised, then this patient is going to be flagged for assessment of what indicators do they have that suggest their quality of life is very poor, and how much do they actually know about their disease. Has anyone talked to them about advanced care planning? And we're going to roll this out for 3 months and try to do a bit of a survey as to how well we're doing with some of these questions and where our needs need to go in the future. And so I'll stop there for questions, but in summary, I hope that you've taken home the point today that heart failure incidence does increase with age. It's an important marker of prognosis in these patients. It is not the only disease that they have, and treating heart failure involves treating all of the other systemic comorbidities that are present. I believe that optimization of medical therapy is key, but I also believe that as we move further together, hopefully, that we can work collaboratively in some of these very complex issues with regards to heart failure, advanced planning, and palliative care. And I think that ideally, a collaboration between family docs, geriatrics, the palliative care team, and ourselves is really the model that needs to take place to help improve the quality of life of these patients and help to keep them out of hospital. So thank you very much for your time today.